history is of 65-year young male who is having a painless gross total hematuria with clots. And over the last months, there's episode of three episodes of hematuria. It's a painless clot. So my question to you, Sanjay,
Yes,
again, examiner's favorite question. Once you open the mouth that this patient is having hematuria, the 1, 2, 3, the question follows. So what would you like to know from me when the patient comes with a history of hematuria?
sir, the mode of onset of hematuria, then the associated with pain or not, whether and the type of hematuria, whether it is present throughout the day or only it is or it has uh, spontaneous, it has resolved, and then whether at the starting of micturition or throughout the complete flow of micturition or at the end of micturition, and then is that the first episode or any previous episodes are present, sir? And associated any flank pain or associated lithuria, associated the clots, so what type of clots are present, any history of fever present? I would like to ask all these, sir.
Okay, no, we have gone beyond hematuria. I was just trying to list the information related to hematuria because hematuria is one of the very alarming symptoms. I think if there is a pain, patient can sit at home and ask for some sort of medicine from a local practitioner, or just try to wait for any convenient day to report to the hospital to seek intervention. But when this type of symptom comes, which is a painless, nobody will stay at home. They will rush to the hospital. So my point was is to know from you what are you thinking about this hematuria and why you ask so many points, all this and all that. You have to make me understand.
Yes, sir. The first 65-year-old patient with this kind of hematuria, my first thing would be to rule out the urothelial malignancy, sir. So all these features, typical the painless and the total hematuria and associated with clots, are all features of the urothelial malignancy, sir.
That's all. Means like your whole focus was on for malignancy. Okay, fine. We'll take that point. Amit, you want to add what Sanjay wanted to convey?
Sir, any patient presented with hematuria, there is a likelihood that 50% of chances, 50% of patients have any etiology behind it, and 20% chance of the malignant condition being associated with hematuria. So this is the basic reason why a patient presenting with gross hematuria in an elderly male, we have to evaluate. We can't leave him unnoticed.
Okay, so let me come here. The common question which examiner asked to the residents is in form of how severe is the hematuria? Tell me the color of urine, how bright red, dark, or it is light red. This gives it some idea what this patient is having, the timing which he has already mentioned, initial, terminal, global, associated with pain. Pain means like pain has to be very particular in defining whether it's a flank discomfort or it is something like a colic. So that it precedes the hematuria or it is after hematuria. All these things become important. He has given the history of clots. Again, would like to know more about the clots, the shape of the clots. Voiding symptom he has already mentioned. This will give an main purpose for us is to find out, number one, what is the site of his bleeding, is upper tract or the lower tract, which is very important for me so that I can keep some differential diagnosis. And number two, what could be the pathology? One pathology you have kept in your mind, both of you, was malignancy. Yes, I'll always keep malignancy as number 1, 2, number 3, always malignancy with this type of presentation, but definitely there will be some other causes which can give rise to hematuria. So the idea of whole history related to hematuria in going in more detail, in more depth related to hematuria was to find out the seat of hematuria and probably pathology. Very important. Means like you should be very clear when somebody is asking you what could be the causes other than hematuria. You should not jump to tell about the very rare causes. Say something like somebody say tuberculosis, AV malformations, trauma, without any history of trauma. So you should be very selective when you are talking to the examiner. You speak less, but don't give diagnoses which are haywire from the present history. We may be wrong in picking up the diagnosis, but our idea of this is we have to just pick up the threads, knit them together, and get to a common diagnosis in the form of 1, 2, 3. Okay. So this was the important points which you should be knowing in relation to hematuria, in relation to the findings associated with hematuria, the clots, because all this is important. Severity is important. If the patient is having recurrent bleeding, I expect this patient, he may be having, or she may be having a little bit of, low hemoglobin, because if it's a recurrent and it's a global hematuria, the recurrent episodes are happening, I have to be a little careful. And if it is giving me some clue related to the presence of clots or the vermiform, I'll think of something maybe related to upper tract. It's just a speculation, but the idea is again to fix whether it is a kidney or ureter, or it's a bladder or prostate or the urethra, and whether it is a neoplastic lesion or whether it's an inflammatory lesion or some other lesion. Okay.
Yes, sir.
Now, any other symptoms you want to ask from me regarding this patient?
Sir, any history of previous instrumentation is there? Any patient, the patient is on antiplatelets like clopidogrel or ecosprin?
Sanjay?
A history of any other medication intake, sir, like NSAIDs, phenacetin, or any specific diabetic medication, sir. And then previous history of any history of tuberculosis is present.
Okay. So you have to deal with the patient as a whole. You should not be just focusing only to the hematuria. Whatever other urological symptoms which can be present in this patient, you need to elicit that. One voiding symptom we have already discussed, pain already discussed, but whatever relevant history has to be taken, even if the history is related to hematuria. Now, mild history of LUTS is there, 5 to 6 years, but he didn't take any medicines. There's no history of any flank pain, fever, no prior history of instrumentation surgery. Everything was okay. For the last 5-6 years, mild frequency urgency is there with the minimal decrease in the flow, but patient found it okay, comfortable. He didn't seek any tension. What next now?
That's not getting the question, sir. Sorry, sir.
What next now? I have given you the history now.
So on the basis of the history, we'll form a differential diagnosis, most primarily as a malignancy, most probably the urothelial tract malignancy.
Okay.
The shape of the clots is not mentioned, so we can't differentiate upper tract from lower tract. And since at this age, bladder CA is most common, so our first differential will be CA bladder. Now, since it is associated with LUTS, I can say that either it is located in the trigone or bladder neck, or it may be secondary to the BPH because patient is a 65-year-old.
Okay. Sanjay, you would like to add anything more than what differential diagnosis he has kept? He has kept a sole diagnosis of bladder malignancy. So a question to you is, would you like to think other than this diagnosis?
Yes, so my second diagnosis would be a bleeding from a prostate, so like a prostatic pile. That would be my second diagnosis, sir. My third diagnosis, probably I would think about a renal mass. Probably, I would restrict to these two, only these three, sir.
So renal mass, you won't say real neoplasm. Mass may not bleed, so renal mass should be specific. Now,
renal neoplasm. Okay,
now we'll summarize. We are thinking of 3 different conditions: the bladder malignancy, the renal, or I'll add after renal upper tract malignancy also. Okay, upper tract urothelial malignancy. Okay. And we have definitely kept the prostate as one of the diagnoses. Okay, I'll come to the prostate as a cause of painless global complete hematuria a little later. Now, with this diagnosis, what do you like to do next in relation to examination of this patient? What are the areas? Because let this be a broad round or short case. You'll be very specific to the examiner. I want to look 1, 2, 3 specifically in systemic and the physical examination. Because you have already focused to narrow down to few diagnoses. So you will be very particular that I want to see this is very quickly.
Yeah. Yes, sir. First, general examination, I would like to see the patient is anemic. I would like to see his nourishment status, sir. And the abdomen examination, I would like to see look for any mass. I would like to palpate for the flanks and look for the hypergastric region. And and I would like to palpate. I would like to do a digital rectal examination and look for any look for the condition of the prostate and any mass palpable per rectum, sir.
Okay. Amit, you would like to add something?
Sir, in general examination, I'll see for the edema, because if kidney is involved, CKD, patient might be renally compromised. So pedal edema and facial edema I look for. Secondly, the pulse BP is important in this case. BP is important in this case if it is a hypertensive patient, which may predispose the patient to see a bladder. And other than that, he has covered. Sir.
Okay. Now it's very important when you are specifically asked what are the relevant area you are going to look. You keep yourself focused to. I'll say, if I have to answer this examination related to diagnosis, I kept the diagnosis of a malignancy. I would like to know whether this patient who is having hematuria, recurrent episodes, whether it's anemic or not. Whether this sort of diagnosis has some palpable masses in the flank or the bladder is palpable because of cord tension, I don't know. Obviously, the rectal examination and biometric examination too will be important if you are keeping bladder malignancy. Second will be my examination related to the overall health. Whether this is a 65-year young or 65-year-old, we don't know. So we are not talking about chronological age, the biological age. How fit is the patient? Again, if there is no history of diabetes and hypertension, I don't think we'll have something like pedal edema, but definitely overall health, something you can say performance status, all these things become important. So why I'm discussing all these things? Because this, let us assume examiner comes, this is a ward round. One complaint will be given and you have to be very specific, very clear what you are going to say to the examiner, because you have only 10 or 15 minutes to discuss this case. So very relevant. First examination will be what my relative diagnosis, what I have to look. And I have to, because if I am keeping 1, 2, 3 all malignancies, I have to assess the overall health performance, because I may have to treat this patient surgically. So I need to know the overall status of this. Okay. So what next now? Everything has been given to you.
Yes, sir. Next, I would like
nothing contributory in the physical exam and the local exam. There is nothing contributory to your diagnosis, whatever you have kept.
Yes, next, I would like to ask for some investigations. So basic investigation. I will start with the blood investigations. I would like to do the complete blood count, renal function test, a liver function test, a coagulation profile. I will also like to do a urine routine examination, and urine cytology, sir. And since he also gives history of LUTs, I would like to do the serum PSA, a uroflowmetry, and I would like to get a ultrasound of the KUB region done, sir.
Okay. Amit, would you like to present in a different way to me?
Sir, I'll start with there are 2-3 ways in which we proceed. One is the investigation.
You have to tell which way you will like to say.
Sir, investigation to confirm my diagnosis, investigation for metastatic evaluation if it is a malignancy, and general investigation to for the surgical fitness.
Yeah. So what our aim will be, investigation focused to a diagnosis, because we are examining the patient and we want to know what we are dealing with. It's not a simple complaint of flank pain where we can just spend some time in getting all that. Now we want to know, we are anxious to know with a very alarming symptom of hematuria. So if I have to say in the exam, I'll be telling about the investigation, which will go into the route of forming a diagnosis. Then definitely there are some investigation which you have numbered, from the hematology to the serum biochemistry, including PSA, for the overall fitness and all that. Okay. So Amit, if you have to go with this frame of mind, what you would like to do first?
Sir, first we need to confirm the diagnosis, and for that the first test which is easily available is ultrasound abdomen KUB region, sir.
Okay. Now tell me what you want to see in the ultrasound.
Sir,
you are doing ultrasound. Patient is with you. You have got a good ultrasound machine. What will you do?
So my first diagnosis was
No, leave
malignancy.
aside. First, second, third, whatever diagnosis is there, ultrasound has to be used to confirm everything.
Sir, ultrasound first starting from the kidney, I will be looking for the kidney. My primary area of focus is bladder. So I'll start with the bladder, the size contour of the bladder. The bladder should be adequately filled. If any mass lesion is present in the bladder, the location, the size of the lesion, multifocality of the lesion. Now, along with that, I will see for any prostatic enlargement if it is there. And in that, the lower ureter I can assess for hydronephrosis, for ureteronephrosis. And coming up to the kidney, I look for CMD, corticometric differentiation, and hydronephrosis for the patient.
Okay. Sanjay, would you like to add anything in the ultrasound, or you are comfortable with this, whatever finding he is looking for?
Sir, I would also like to look at the bladder wall thickness and presence of any other the content within the bladder specifically, and would also like to do repeat ultrasound after voids to do a PVR, sir.
Okay. So what we are doing is we are doing ultrasound for picking up all the possibilities. We are doing for bladder mass, we are doing for renal mass, we are doing for prostatic condition, prostatic enlargement. So we are doing ultrasound and whatever Sanjay is telling, he will do on flow rate also and do on PVR also. Am I right? So if I put together what Amit has said, he has very nicely elaborated how he will do the ultrasound and what he is going to look. And if I add whatever Amit has missed Sanjay's finding, I think this is the answer examiner will be looking for. He won't ask further than that. He will say what next. So we go with the ultrasound. The upper tracts were normal. This is the bladder mass. I'll give you the finding. And upper tracts normal. There's no other mass in the pelvic system, no mass in the parenchyma. The bladder was adequately distended. A heterogeneously hypertrophic mass of the size of 3.9 centimeter. Prostate was 16 cc. So are you happy with this report?
Yes, sir.
Okay. So I'll summarize now. Actually, the report should have covered so many things. It should have brought into our attention the number of tumors, the size, the shape and the appearance, which is very, very important. The appearance of the tumor has a very major role to play in the what you can say management or the prognosis. We know that papillary tumors are different from solid nodular tumors, which are not raised. The base which is wide, and the tumors which are pedunculated, again, they are different in the terms of their behavior. It is not whatever Sanjay added, the wall. It's not the surrounding wall. That means the wall just adjacent to the tumor, but the rest of the bladder wall. So all these things become important. And somebody says, okay, this patient is a hematuria, you want to rule out from the clot and all that. You should be very ready to answer that no, this is a tumor, this is not a clot, and you should be ready to answer why you thought it is a tumor and a clot. This is again a favorite question of the examiner. And as well as you clearly mentioned that you will look for the prostate, upper tract, hydronephrosis, and the tumors. But very important, the ultrasound is a little bit, what you can say, its bladder is not full. It has some poor sensitivity. More than 1 centimeter tumor can be easily picked up, but the tumors less than 5 millimeter or the bladder is not adequately distended, this can be easily missed in 10% of patients. So it's very important how you keep this ultrasound and your adequately distended bladder. I look at these findings. This is the impression you have to convey to the examiner. Okay. Now we did flow rate, and flow rate was 8.8 and PVR was 0. So now this is the ultrasound finding. And what next now?
Sir, I would like to get a baseline creatinine done, sir, because in view of the tumor being a large size tumor, I would like to.
Whatever you asked earlier, the hematology, the biochemistry, the renal function, the liver function, everything is within normal limits. Giving you all the reports.
Yes, sir.
Now, did you miss anything?
Urine for cytology, sir.
Excellent. Amit, would you like to do cytology?
Yes, sir.
Now, patient is having hematuria. This is again a favorite question of examiner, whether you would like to do cytology in a patient who is bleeding, having gross hematuria, or you would like to put it at some later time. Again, you should know how to answer this question. And the presence of blood with RBC, which are non-nucleated, and the presence of malignant cells, which are totally different from RBC, how you can separate all these things. You should be very clear what you have to answer. You can say, yes, I want to do when the patient is not having active hematuria, or you can say, I will not do at this point. I would like to go with the other investigation, and I'll do it at the later stage, because the cytology is important. Why it is important, Amit?
Sir, cytology gives the grade, suggests the grade of the tumor, sir. Its specificity is approximately almost 100%, 90 to 100%.
No, what do you mean by it suggests the grade?
Sir,
I didn't. You have to give a complete answer.
Sir, if the cytology is positive, we can be 95% sure that the tumor is high grade.
Okay. What do you mean by positive cytology?
Sir, positive cytology, as in it's graded according to Paris classification system, in which 6 grades are there. According to that, grade 4 and 5, grade 4 and 6 are highly suggestive of high grade urothelial carcinoma. So if the patient fits into the
what is 6 and what is 5?
Sir, 6 is highly suggestive of
suspicious of.
4 is suspicious of high grade urothelial carcinoma. 6 is highly suggestive of high grade urothelial carcinoma, and 5 is low grade urothelial neoplasm.
No, other way around. Sanjay, can you answer this question?
Yes, sir. The Paris grading has 6 types. So starting with adequate, negative, low grade urothelial neoplasia.
No, my point is fine. My point of asking this question was this: you should know what is the 6 types of reporting which is done based on the Paris cytology. Number 1, what does it signify? It signifies that is a high grade, including carcinoma in situ, which is considered a high grade, what you can say, non-muscle invasive bladder cancer. Okay. So this is again a question which has some tricks involved in the presence of hematuria, in the absence of hematuria. You do cytology or not? What do you do? Okay. Now we have given this cytology, which was what you can say positive for malignant urothelial cell. Okay. Next, what do you want?
Next, I would like to do a contrast CT of the KUB region, sir.
Contrast CT of KUB region. Amit?
Sir, contrast CT of the KUB region, sir.
Okay. Why you want contrast CT? Why can't you go with the management without CT?
So since the tumor was more than 3 centimeters and there was second ultrasound even showed multifocal tumors. Although
no. That is. I just wanted to show you how the small tumor can be mixed, but it is a single tumor.
Sir, size of the tumor is more than 3 centimeters, and so in this case, we'll go ahead with a CECT exam of the KUB region, sir.
Okay.
And also positive cytology.
Okay. Okay. Let us assume I say cytology is negative, and this tumor size is 2.9 centimeter.
I will stop with the ultrasound, so I would not proceed with the contrast CT of the abdomen. I would like to proceed with the cystoscopy, sir.
Sir,
cystoscopy and proceed, sir.
In case it is a broad base or sessile tumor, I'll still like to go ahead with a CCT, sir, irrespective of the size.
Okay. Okay. Now I come to the same questions. If you are asked in the exam, what next? So number of options come. You can have a CCT but when you are telling contrast CT, you should mention that I will also have CT use, contrast use. Okay, I'll ask you why. Then whether you would do MRI. If you are reading the latest literature, whether I'll do an MRI or MP MRI, or whether you would like to do PET CT. You have a machine in Apollo which is PET CT, whether you'd like to do. I'll come to the bottom investigation. PET CT, would you like to do, Sanjay, in this patient?
No, sir.
No. Let us assume this tumor is 5 centimeter, a solid base, a big tumor occupying almost what you can say the base and the right lateral wall. Then
I will still not do a PET CT, sir.
That's the answer you should say. Don't jump for because this has not found any mention in any guidelines and all that, especially as a first investigation. Okay, so you should not, even if examiner provokes you to say no, this is not the investigation you will do. Now coming to the CCT and CTU, why we like to do CTU? You should know what you are going to look at the CTU. Now, if you see the European guidance, which are a little bit of, you can say, more easy to follow and more clinical oriented, it mentions the role of CT in few select conditions. Am I right, Amit?
Yes, sir.
Yes, sir.
Yeah. So they say if now if you see if you are doing CCT for a protocol, hematuria protocol, that is separate. Here we are talking that we are not following hematuria protocol. We have got an ultrasound and we have found a tumor. So this is not a hematuria protocol. You are going a CT or CTU. So we like to choose all the investigation according to tailored to the patient. Every patient has a different what you can say way of being managed. So if you see the AU guideline, it has a what you can say a trigonal tumor, what you can say a high risk tumor or a multifocal tumor.
Multiple tumors. Yes.
Yeah, they found a mention. But the question here is what we are doing for, why we are doing. Is this going to change your management?
Sir, it is a field cancerization change. So there might be small associated lesions or CIS or associated urothelial tumors. So we have to rule out all these things, sir.
Okay, so what urothelial tumor means? Upper tract.
Upper tract tumors.
That's why European guidelines mention that finding of upper tract tumor is more when you have a tumor in the trigon and multifocal and iris. That is why they asked it. But our tumor is sitting nicely in one place in the right lateral wall around 3 or 3.5 centimeter. Okay, so my question is, it is the way you deal in your practice, the same way you have this. Yes, it is our protocol to do all the management of bladder tumors by getting a CCT with CTU. So I'll go for this. And in this CT, I'll be looking for 1, 2, 3, 4, whatever you want to say. And this information from CT, you should be able to answer to the examiner. Okay, tell me what is the finding you will look for if you want a CCT.
Sir, apart from that, I would like to confirm the same findings on ultrasound, sir, about the tumor characteristics and number, location. So apart from the routine thing, I would also like to look for any the perivesical standing, anything is there, or any regional lymph node involvement is there, and also whether there is any upper tract involvement, sir.
Okay. Okay. Now again, I come back to the same question. When you are talking to the examiner, when you are CT, you have to be very, very specific. Is this CT scan meant for T-staging?
No, sir.
Yeah. So what in when you are describing this, you are asking for that, you are looking for this and all that. So this is the CT is not a correct investigation to do a proper T-staging. However, if there is what you can say the node size of this much and all that can be easily picked. And if because we have not proved that we are dealing with a muscle invasive or non-muscle invasive, we have no idea. So this will not be a correct way to what you can say tell to the examiner that you know the diagnosis beforehand only, because either is a muscle invasive or non-muscle invasive, you have not to convey. So you have to be very specific what you are going to look at, and these are the CT findings which I'll just summarize as 3.6 into 2.8 into 2.4 centimeter mass without any hydronephrosis. There's no evidence of any fast standing and infiltration. Tiny lymph nodes are there on the CT. Rest of the organs are normal. Kidneys are normal, and these are the findings. So to summarize, when you are talking of CECT, first thing you have to do upper tracts. Upper tracts is mainly for hydronephrosis. A unilateral hydronephrosis is an evidence of muscle invasion. Okay.
Yes, sir.
Okay. but our ultrasound does not pick. But let us assume our CT has picked. It will tell us the function of both the kidneys. That's what, because if you have got a CCT, it will tell us, and you have to convey that. It will tell us the function and either finding which is the upper tract and the mass, or in the pelvic calcium system, or you have to describe about the bladder mass. I will not say that you should go for T staging, but you can pick up N and M. And T is not staging is not picked up in the CT, and it is meant only for picking up extravascular disease. Am I right?
Yes,
Okay.
sir.
No, but coming back to again, the EAU mentions clearly the few conditions, but if you see the AU guidelines, there is a hematuria protocol is a standard investigation of CT urogram. Okay. Now coming to the second investigation, which we were discussing, MRI. Again, any knowledge about use of MRI in the evaluation of bladder mass?
So the upcoming scoring system is coming up, so in the form of VIRAD scoring, sir, but it's still not. It is the routinely used, sir. In use.
Okay.
At the present thing, MRI does not have any superiority over CT, sir. Contrast CT.
Amit,
Sir,
your answer?
Sir, MRI is basically used for VIRAD staging, MP MRI these days, but as already mentioned, it's not in the protocols yet, sir.
So MRI will not change my plan. Number one. Number two, I have to go and prove it histopathologically what I am dealing with and what is the T stage and the grade of the tumor. That histopathology will give. But if you see the VIRAD scoring from 1 to 5 has given some idea of what you can say about the detrusor invasion. So, but again, it is investigation. You need to prove it histopathologically. So this is again is a multi-parametric as we use for prostate, with the anatomical delineation done by T2 weighted images in the form of high signals, and you have diffusion weighted and LDC values. And post contrast, you'll see the early enhancement and quick washout from the tumor. All this is important. This is just I kept the picture for our protocol of doing MP-MRI for the bladder muscle, because this is we are doing it a study point of view. So now we have done a CCT. You have got the imaging. Now what next, Amit?
Sir, we'll take anesthetics fitness since he's a COPD patient, and then after that go ahead with planning for surgery.
So surgery means
in this case we'll plan a TURBT, sir.
Okay.
Transurethral resection of bladder tumor.
Okay. So if we are talking of transurethral section, there are a few things which will come as a sort of question: what procedure, TURBT, which anesthesia, how you start, and how you do the TURBT. Now I come to the technique, anesthesia and technique. Sanjay, can you tell me how you do in your center the TURBT, and especially keeping in view this patient who has got a 3.6 centimeter lateral wall tumor, which is a little bit of wide base of 2.2 centimeter?
Yes, sir. I would request for a general anesthesia, sir, but if he's unfit for a general anesthesia because of COPD, and with spinal anesthesia, under spinal anesthesia, so along with the operator block, sir. I would like to do a bimanual examination before starting my procedure, then and obtain a clinical staging. Then after that, I would like to do a cystourethroskopy, assess the urethra and completely look at the bladder. I like to confirm the findings of the CT, and then I would like to proceed with the TURBT, sir.
Okay. Amit, my focus questions: which anesthesia you prefer, and how do you do the bimanual examination?
Sir, anesthesia we do under spinal, but given a chance, general anesthesia is preferred, sir.
No. You have to be very specific now. The spinal anesthesia, it will be with block, obturator block, or without?
Spinal anesthesia with obturator block or general anesthesia.
Or general anesthesia with what?
Muscle relaxants. Muscle relaxant we can add, sir.
Okay. And how about bimanual examination? At what step you do?
Sir, bimanual examination we do 2 times. Once after the anesthesia and once after the procedure is over.
Okay. After the anesthesia means
Once the
how
patient
do
is in
you,
position.
you have to do an empty bladder.
Yes,
Am
sir.
I right?
Empty bladder.
So,
Yes, sir. We put the
Empty
foot.
bladder. Yes, sir.
Empty bladder.
yeah. So why I'm asking this question? Because the examiners are fond of asking this question. When you will do, usually the protocol is you always tend to do a urocystoscopy with the sectoscope is bigger, 22, 24. So usually the cystoscopy with 0 degree, 30 degree, 70 degree. You use 17 French. You start from urethra onward, look for all the, from the meatus onward to the whole urethra, to the bladder, all along the bladder, and making note of ureteric orifices and everything, and then empty the bladder. That is the time you do bimanual. That's the time I do the bimanual examination before starting the section. That is okay. And then is the standard technique of what you see, that TURBT. And the common question which is asked is, do you do the random biopsy when you are resecting the tumor or not?
Only if there are any suspicious regions, I would do a random biopsy, or if the tumors at the trigone or the bladder neck.
No. See, Sanjay, what you have to see is very important.
Yes, sir.
When we are asking question, you just keep in mind that CT picture and ultrasound picture. Don't
Okay, sir.
Don't lose the track. Here, the examiner
Okay,
has
yes,
your case in mind. He doesn't want you to talk theory. He wants you whether you will do random. So your answer will be what you have told. You are not
No,
going
sir.
to talk anything else.
No.
So yes, I'll do in this condition. Which are this condition when you do random biopsy?
So when there is a positive cytology and the negative cystoscopy, sir.
So that's what your cystoscopy is showing. It is a bladder
Yes,
mass.
like a tumor. Yes.
So again, this question again I have put it because this is a question asked, and the what you see, you go off the tangent.
Yes.
You will do only biopsies, not random biopsy. Biopsy of the suspicious lesion. Random biopsy will not do. Okay,
Yes,
random biopsy is that's why I have put question mark, because a question is asked in this way only. Would you like to do random biopsy? No, because this is a tumor, and where you find a suspicious area, what appearance look of red velvety erythematous lesion away from the site of tumor, anywhere in the urothelium, you will biopsy them. Okay, but other areas you will not biopsy. Then second
Yes, sir.
question comes is whether you will do a prostate biopsy or not in this patient.
No, sir.
Yeah, so again, because we tend to go a little more theoretical, yes, you have to say this tumor is where located. It is, the prostate biopsy has its own indication when we do a prostate biopsy. So you have not to talk which is not relevant to your case. In my case, my diagnosis will be a good thorough inspection of the urothelium from the meatus to the bladder, and then doing a good TURBT. And now we come to the TURBT. Amit, can you describe how you do the TURBT in your setting?
So TURBT, first we start, starting from where should I start, sir?
From you have a patient is anesthesia. You have we have done bimanual examination. Everything we have done. We have got a sectoscopy.
So we start with cystoscopy. We examine the urethra, bladder, everything, and once the tumor is localized, we position the tumor, see for the ureteric orifices, how far is it from the ureteric orifices in this case, and then we start resecting the tumor either en bloc or piecemeal. We do piecemeal.
No. Again, Amit, we got again. See, you told en bloc or piecemeal. Again, we have not to talk theory now. You
Okay,
have got
sir.
tumor now in your CT. You know the CT picture.
Yes, sir.
You take a call on that.
Sir, we do it with
You have not to say or. You say what you are practicing and what you are going to do. Or will not be decided now.
So using a 26 French resectoscope with a monopolar cautery, we do piecemeal resection in this case. We start with the periphery and leave the base at the end to be resected. We resect the tumor completely. After resecting the tumor as such, we resect the base, and separate biopsy is taken for the deep muscle and it is sent separately.
Okay. Sanjay, anything you want to add in his technique?
I would use only pure cutting current, sir. I would not use the cautery at any point because since it is seen involving the orifice.
Okay. Now I'll come to how the examiners ask. Usually the question asked is, what are the types of resection? Fractionated, which you have already told, en bloc. Okay. Now, our tumor is a little more than 3 centimeter and a wide base. Of course, there are some centers who do en bloc. I have done en bloc resection for a tumor bigger than 3 centimeter with a Colin knife. But again, what you are practicing, I'll do a fractionated section where I'll first take out the exophytic part, and then I'll come to the base where I'll take the separator section and give it for a biopsy for any infiltration of the tumor. Second question they are asked is, okay, what form of energy you use? Again, what you have told is monopolar, bipolar, or laser, whatever you practice, same thing. Majority of the centers will say monopolar. Of course, there are some centers they will say we have bipolar and we do bipolar. Few centers have started doing with even thulium fiber, again en bloc also. But again, is the way you practice, same thing is gonna. Now coming to the monopolar versus bipolar, what I say is there are a few things about bipolar. It doesn't decrease any incidence of
Operator jerk.
That is for sure. But one important advantage with the bipolar is, as compared to monopolar, it reduces the, what you can say, quaternary artifact. So when you are giving a base biopsy, we are doing monopolar, sometimes your pathologist may say quaternary artifact are unable to comment on the muscle. But with bipolar, usually the specimen architecture is preserved and the pathologist is able to comment a little better. But coming to the whether it prevents optic reflux and all, it may decrease, but it doesn't prevent the reflux. Now, sometimes examiners are fond of, okay, this is a tumor in the lateral wall. Let us say we have a tumor which is near the orifice. Again, you should be able to handle. There are few complex situations which is theoretically given at that point to differentiate a common candidate from a little better candidate and better to a much better. How will you circumvent the situation when a tumor is just hanging near the UV junction? So again, you have to be very clear in your answer. Yes, I will. There is some mention of literature when you find a tumor in the initial cystoscopy, the tumor in the UV junction, you should do a ureteroscopy. There's a mention in literature that you should do ureteroscopy to find out ureterus normal, and then a resection, whatever resection you are doing, and a very careful coagulation, because you are in the orifice, you don't want to scar the orifice in the term of narrowing, and you should avoid putting a stent. But if it's a tumor is in the UV junction, you are seeing it is spouting in the orifices, this tumor has to be resected very nicely until you see the muscle. But the only thing is you have to be very careful. You don't detach it from the uterus. It should not get detached from the wall. And then you have to stent it. And these patients have to come in after 2 weeks with the stent removal and ureteroscopy again. And if a residual tumor is there, again has to. These are the question which is usually theoretical situation is given, because we know that the bladder tumors tend to occur lateral wall, the base of the posterior wall, the dome, but it has, but the chances of having a primary tumor is a little low. But you can find an associated secondary extra tumor in the UV junction. You should be able to handle that. So coming to the tumor which is in the lateral wall, so that is the examiner's favorite question: lateral wall and the obturator reflux. Amit, you will answer this, how to decrease the chances of obturator jerk during a section?
Sir, first we are going with general anesthesia, then not adequate distension of bladder. Bladder should be minimally distended. And then using the bipolar sometimes helps, or laser prevents. Laser, I'm not sure, sir, it prevents. But they're documented that laser can also be used. Then before surgery, we can give an obturator block, which can either be given by the Labart technique, or there are 3 techniques described. So Labart technique, then
okay. So I'll quickly summarize this lateral wall tumors resecting leads to obturator reflux. And what happens is you will find a sudden jerk and your loop will go inside. And then what you are scared is you don't know how much loop has gone inside. There may not be bleeding at that point because muscle contract and you don't know what damage you have caused. You are scared whether you should continue with the section or you should come back later after 2 weeks to see that area. So this is very common in elderly patients, especially the thin patients and the female where bladder is usually very thin. And you should, if you are using a GA, you should be with a complete paralysis with the neuromuscular agents, and try to do resection with a half distended bladder. Don't distend the bladder very full, and short bursts of short excursion of your bipolar, or what you can say monopolar loop. Keep it very close to the tumor. Dissect in small pieces only, and you can decrease the cautery settings, both cutting as well as the coagulation. Bipolar, again, which I have already mentioned, it doesn't what you can say, the objective flux is not totally gone. It may decrease, but it's basically advantage is giving a good tissue at the end. And what Amit was telling us, that obstructor block, again, sometimes to differentiate between the good, better, and the best, examiner may ask, how do you give a obstructor block? You should know the ultrasound guided and the anatomical with the nerve stimulator, how to find the obstructor nerve and give a block. Okay. Now coming to, we have done anything in the postoperative you want to do? We are just doing our TRBT. We have finished the TRBT.
Put a catheter and do a repeat bimanual examination, sir.
Excellent, excellent. Amit, anything?
Sir, in the postoperative, immediate postoperative, if it is a complete resection without perforation, we can go ahead and plan for mitomycin seizure.
Okay. Now coming to both these points. Sanjay, when you are talking of the bimanual examination, the type of tumor which we see are very small. They are not, it's very difficult to get this tumor, what you can say, bimanually palpable. The bimanually palpable tumors are totally different ball game. You will see on the CT which tumor will be bimanually palpable and which will not be there. So this is, you again, very judiciously, you stick to the finding which you have seen in your imaging. Okay, so you can easily say this tumor is not going to be bimanually palpable, very small tumor. It's very difficult to, and at the end, nothing will be there. But again, your point is valid that you should know what is the significance of a tumor which remains bimanually palpable. And the Amit point is very clear that he will like to put mitomycin.
Sir, I would like to clarify, sir. This is a 3.9 centimeter tumor with it's not a low grade. So in this case, I won't do mitomycin.
Yes, I am coming to that questions only. Now, when do we put the mitomycin? There are two thoughts. One is, what is the purpose of putting a mitomycin?
Mitomycin is to
tell me. Go ahead.
Mitomycin is to prevent the recurrence, basically destroy the floating cells, and also to also destroy the remnant cells at the site of resection, sir.
Excellent, excellent. Amit, your point was is you will not give.
Yes, sir. In this patient,
okay.
I will not give.
No, I'll come to. Two views, both are well accepted. When you feel that your patient, according to the clinical staging, falls into a risk category where you are thinking of giving an adjuvant treatment because of some particular risk category, you are giving something adjuvant, then probably mitomycin may not have role. Am I right, Amit?
Yes, sir.
Okay. Now, on the other hand, the mitomycin has been, there have been reports published where with every section they would like to do put mitomycin, even if it is a recurrent tumor, because it just prevents the floating cells, circulating cells, and prevents the reimplantation. So every section they will put a mitomycin 30 or 40 milligram and 50 ml and keep it for 1 or 2 hours. So both ways. But if I have to think, I'll think, oh no, this patient is already 3.9 centimeter. The cytology is positive. It is going into a different risk category and probably needs an adjuvant treatment with a different agent. So I'll say no, I'll not put that. But you, in both ways, you are right, and you should be able to handle this question. Okay. Now the question asked is, let us assume we are this is a 3 point. We keep it as a 3, and what drug for mitomycin is not available? Supposing mitomycin is not available in your Apollo hospital.
Hepirubicin or pirarubicin is advised. Hepirubicin or pirarubicin is advised.
Okay. We are talking about, okay, what better than, what answer which is better than that?
Gemcitabine, sir. Gemcitabine, sir.
Excellent. That is the correct answer. Gemcitabine means there are many centers where instead of mitomycin, people are putting gemcitabine because of what you can say is cheaper than mitomycin, surprisingly cheaper than mitomycin, and it has what you can say more safe than the mitomycin. So this we should be knowing which drug is the mitomycin. If it's not available, the centers which is gemcitabine, you can put gemcitabine before mitomycin. That is also when you have to put. You should be very clear. You have to put when there's no hematuria, there's no perforation, and the urine is absolutely clear, and in a condition where your irrigation can be stopped without any adverse problem. Am I right? Because you need to keep, there is a mitomycin has to dwell in the bladder, it has to act. Okay, so your urine should be absolutely clear, and you should be not expecting any bleeding from any what you can say the raw area or the area of resection. Because you will be stopping the irrigation for some time. Those you should be very clear, and reverse you should be clear, and you have already mentioned why you are giving it. That is the question now. Now, this patient had TURBT done. The patient got a mitomycin within 2 hours, and it was followed by irrigation for 1 day, and foliage was removed on the post-op day 3, and patient got discharged. Now, question to you, Sanjay, what you do now?
Sir, I would wait for the histopath report, sir, and would discuss with the patient regarding further management based on the report, sir.
Okay, you will wait for the histopathology report. So, if I have to ask you in the histopathology report, what are you thinking? What you want to know in the histopathology report? Without which you will think that probably the information is not complete.
Yes, sir. The type of tumor, sir, whether it is urothelial or any other different types of pregnancy, then the depth of invasion I would like to know, sir, okay. And also the grade of tumor, sir.
Okay, very good, very good. Amit, you want to add?
Sir, lymphovascular invasion.
Okay, what else? Okay, now I'll come to that. You should be very clear that you confirm the diagnosis, whatever you are, epithelial carcinoma, transition cell carcinoma, histopathology, right? It's not, you look for the grade, yes, low grade or high grade, and you should be lymphovascular. And the variants, you know, that very common to find sometimes variants in the histopathology, you should be very clear. And here comes the question now, when examiners take you, again, to whether you want something else. Yes, if the histopathologist is good, if the uropathologist is good, you would further like to subclassify the T stage, because that also has important bearing in the further planning. Though my cytology is positive and the patient is having a T1 or T tumor, TA or T1 tumor, we don't know. So I would like to go for a subclassification of the T tumor if my pathologist is good. But before that, I'll come to this slide, which I have kept it to be. This is a very published in a very I think in a World Journal of Urology. This is by Harry Hare. Who has published many articles on transitional carcinoma. This is the way you should be putting the TURBT. It has 10 points, and if you keep this in your mind, these 10 points, your knowledge about the disease, your follow-up of a patient after TURBT will be excellent. This is assessment of prognostic factor, which again, the number of tumor, the size of the largest tumor. Which I didn't ask, is how to assess the size of tumor. The loop width. Loop width is 1 centimeter. You try
1 centimeter.
To measure with it. Yes. And characteristic of the appearance, the sessile, the nodular, papillary, or the flat one, which is like almost carpeted along with the wall, mildly raised only, and any areas of carcinoma in situ, which is red velvety patch you are seeing away from the tumor, and the C stage, the clinical stage, which it is a TA, T1, T2, T3, T4, And the intraoperative or the bimanual examination under anesthesia, whether complete resection was possible, whether you could see the detrusor muscle at the base, any perforation was seen. This is an excellent way of putting that. Even if you put this notes and 2 years down the line, even if you are not right and somebody else has come, he will appreciate that Sanjay and Amit has put such a nice note. He can easily, what you can say, the quality of notes will be appreciated. Okay. Now we come back to the histopathology. These are the things which we asked, and this is the report given to us.
T1 high grade, sir. So clinical staging. T1 HG, yeah.
Okay. What you wanted earlier in the histopathology, they have not given you. Am I right? They have given you only few things.
Yes, sir.
Which is showing the grade and which is showing the T stage. The rest of the things they have skipped. Okay, but you will discuss with the pathologist. You will speak to your pathologist. You will try to find out whether they can give you an idea of what you can say lymphovascular invasion, whether they can give an idea of subclassification of the T1 stage. Am I right?
Associated CIS, sir.
Amit?
Associated CIS also I want, sir, because it
yes, because our again CIS will not come in biopsy if you have not taken.
Okay.
CIS will come when you are biopsying a suspicious area. We are not doing random biopsy. Okay. Random biopsy, wherever you do cytology positive, the cells will implant there. Am I right? Okay. Yes. So CIS, you are owing to biopsy only the areas which look suspicious, not just for the sake of you will biopsy at 8 or 10 areas and give it in a separate container to the pathologist. Okay.
Yes, sir.
Now we discussed what we missed in the histopathology. Now, Sanjay, I supposing I come to ask you one question. Supposing muscle was not what's seen in this specimen submitted, and they have given that muscle properly seen and no muscle involved. Supposing in the specimen they have given the lamina propria involved and muscle is not seen, then what you would have done?
Sir, I would not trust the report, sir. I would again do a repeat the TURB, sir. TURB for proper staging.
Okay. Amit, I am just putting you one theoretical situation. Let us assume the report earlier which was given is a low grade TA. Then what you would have done?
Nothing, sir. Just follow up after 3 months for this cystoscopy.
So what mitomycin has been given, I totally agree with you. Supposing this report was a high grade TA.
Sir, high grade TA, we go ahead with repeat TURBT, sir.
Okay. Let us assume it was a low grade T1.
Still we go ahead with repeat TURBT.
Okay. So mine, I totally agree with this. If low grade TN, I would have been just kept for follow-up. If high grade TA, I would have gone for restate TURBT. If low grade T1, I would have gone for that, but I would have surely wanted to discuss with the pathologist because my cytology is positive. So here is you need to discuss. So you have not to blindly follow what the report has been given. You will say that I like to discuss with this my pathologist, and of course you have in your mind that you would like to do it. This ever. Of course, this term is called a restate TURBT. It is different from the other term which is called a completion TURBT. Am I right?
Yes, sir.
Completion TURBT, large tumor, you have removed a part of it and you know that you are going to come back after some time to do a complete section, or you had an operator jerk, you were halfway, you have abandoned the procedure and all that. That is not called restaging TURP. The restaging TURP is the one where we are looking for in the background of high grade lesions and the lesions which are involving the lamina propria. Again, the restaging TURP is important because the literature mentions that even if you have a T1 disease where muscle was present, like in our case, you have still 30% chance of finding a residual disease. Okay, and if it's given without muscle, you have 60% chance of having a residual disease. And supposing it's not even related to high grade, again you have a chance of having a persistent tumor in 51% and understaging in 11%. Why we want to resect this whole tumor is very important. Complete TURBT is our answer. Complete TURBT has to be done, and maximal TURBT has to be done. Complete TURBT, because whatever adjuvant treatment you are planning because of the risk criteria is going to be beneficial if the macroscopic portion of the tumors are removed completely. Okay. Now we have done this patient. We have done the rear TURBT at 3 weeks. We didn't find any tumor or the muscle was seen. What we did is we did section of that area, and we did from the base the cold cup biopsies were sent from multiple areas, which included the muscle. Muscle was seen, but no tumor was seen. Now what next?
So it stands as the T1 high grade tumor, sir. So I would like to counsel the patient to for intravesical BCG therapy, sir.
Amit,
Sir.
Your answer?
Sir, same, sir. After 2 to 6 weeks, after 2 to 4 weeks of second TURBT, I'll start the patient on intravesical BCG therapy. Okay,
you mean to say that something adjuvant has to be given?
Yes.
Okay, and you will prefer to give intravesical BCG. Am I right?
Yes, sir.
Yes,
okay.
Sir.
Now my question to you is, or examiner will ask you, this is T1. G3 or T1 high grade, the different type of prognostic scoring system. The name should be very familiar to you. Whatever you are putting, whether your ERTC scoring system or any other scoring system which you want to put, and you try to subclassify this tumor and try to put into the risk category, and tell the examiner this patient fits into this risk category, and that's why I would like to give adjuvant treatment, which will be of this form to me. And this is the table which I have put, which is in the new EAU guidelines. That's how we put into different risk category. But in the bottom, you see the very high risk category, where why it is put as high risk category, where instead of adjuvant, the patient should be counseled and explain that the role of
early cystectomy.
So this is just to cover that. You should be familiar with the EATG. This is again in the EAU what is NMABC scoring system for progression of the disease. Okay. Now we come to the adjuvant treatment, which according to Amit and Sanjay was BCG. Are you aware of any other adjuvant treatment which can be given in this patient? Our patient belongs to high risk. I just put it into that risk category, ERTC risk category. Our patient is fitting into high risk, not highest risk. Okay. So my question to you is, can we give other than intravesical BCG to this patient?
Sir, the high risk category, I would give only BCGs. I would not give any chemotherapy, sir. Had been an intermediate this group, I would have opted for a chemotherapy as a choice, sir. But since our case being a high risk case, I would still go with BCG only, sir.
Amit?
Sir, patient needs to be counseled that BCG decreases the progression and the recurrence both. So first choice is always BCG. In case BCG is not available, or patient is intolerable, or he has a previous history of BCG cystitis or something, sepsis or something, then we can go ahead with second line intravesical agent, sir.
Yeah.
But first choice is always BCG.
So these are not second line. But again, keeping in view whatever studies have been published, there's no doubt that BCG holds an edge in preventing recurrence and progression in this high risk category, which has more chance of recurrence as well as progression also. All the studies are pointed to that BCG should be an ideal agent to give it. And again, I agree that if BCG cannot be given, you have to think of other substitute like gemcitabine and MMC. And gemcitabine, we know that it is given in BCG refractory. This is one of the
yes, again salvage therapies.
Yeah, So, but again, the preferred drug should be the intrathecal BCG, unless until you have a contraindication that is, the BCG cannot be given to this patient. Now, my question to Sanjay, which protocol you use, what dose you will give, how you will give
Yes, sir.
BCG to your patient?
Yes, sir. I would follow the SWOG protocol, sir, which has an induction phase and the maintenance phase. So, induction phase is the six weekly doses, and then followed by a maintenance dose, which is the 3 weekly doses at 3 months and 6 months, followed by 6 monthly dose up to 3 years, sir.
Okay. This is okay. You talk about the SWOG protocol, the LAMP protocol, and what dose we give? What dose of BCG?
Sir, the 2 vials of the BCG. So each vial consists of 50 milligrams. So that has to be reconstituted in 100 ml of saline and instilled into the bladder, sir.
Amit, would you like to be different from whatever he's saying?
So 2 vials of onco BCG, each vial is 40 milligrams. So 80 milligram total we give in 50 ml of common saline, and keep in the bladder for 1 to 2 hours.
Okay. Now my question to you is: onco BCG contains which strain of
Danish 131, sir. Danish 1331, sir. Danish 1331, sir.
onco BCG. Amit, are you sure this is
Sir, Bovis, Mycobacterium bovis strain.
No. Which strain? We have so many strains of Mycobacterium bovis. What other strain you know of?
Papier is there. Papier is there. Papier, Danish.
Yeah. What else?
Panart.
Huh?
I'm not sure.
Okay. Now, Sanjay, your answer was corrected by Amit in putting correctly that onco BCG is 40 milligram.
40, yes.
Right? Okay.
Yes,
and 2 vial means 80 milligram. Now, strain, both of you have not answered correctly. It is not a Danish strain. Okay, and you should be knowing that in the vial there is always written that how many bacilli colony forming unit is there. That you should be knowing that. And in onco BCG, what is written? Okay, in every, if you see the earlier what we are using was
1 to 1.9 into 10 power 8 colony forming units.
I think the onco BCG has different. It is I don't remember now. It is I think 10 or 1 to 19.2 into 10 raised to power 8 colony forming unit per 40 milligram. So the strain is not, the strain is I think Russian or Moscow strain. That is the onco BCG. But again, what you have to understand is the granular format of the dose. What actually says is, if you see the Campbell also, the 10 raised to power 8 to 10 raised to power 9 colony forming unit are enough. That means 1 vial is enough. But studies have gone from assessing the efficacy of 40, 80, and 120, where most of the studies telling that even if you reduce the dose, the efficacy stays up to 40, and the safety profile is what you can say is more. But 80 is the ideal dose, and what we use usually in our patient is 60 to 80, depending on the what you can say the body weight and the lower urinary symptom which the patient is having. So 80 milligram is the 2 vials is the correct dose, and supposing you are giving 60, you can call 2 patients on that particular day without wasting the half of the vial. This is again this, and how it is given, that you have mentioned that whatever this powder form of this onco BCG has to be reconstituted in a very sterile fashion, and has to be given through how it will be
infant feeding tube, by infant feeding tube into the bladder.
So you will ask this patient to empty the bladder, or you will put a 8 French feeding tube you will empty the bladder, and with a gravity assisted, you will instill the reconstituted dose into the plasma. Just wait for 1 or 2 hours. Patient can turn one side or the other, and after 2 hours, the feeding tube is taken out. The patient passes urine in a washroom, which is again disinfected with bleaching powder. All this gloves, feeding tube, whatever you and all that is used, because it contains a Mycobacterium bovis, it has to be disinfected and goes to the incinerator. This is very, very important, how to dispose of all the contents. So this has to, including your gloves. Okay. So this is the common question asked about how you institute this. Again, this is a precautions whenever you are doing that. Ask the patient not to take much of fluids, tea, coffee, and all that, which causes more urine production and all that. Castration. The common question asked is, will you like to do urine test? Will you like to see the pus cell? Would you like to see the bacteria? Again, literature says even if you find pyuria or culture, it has no what's the correlation with the as a predictor of BC-related adverse events. So even if you have sterile bacteria, you can just go ahead with the with putting a BCG. And there are some studies where even a culture positive also they have gone with the antibiotic. Okay, now.
Sir, excuse me, sir. How do we answer this in the? How do we answer this in examinations? Sir? So before administration of BCG, every dose, should we do a urine routine with microscopy or how? Sir?
No, again, it's the way. If you see the centers who are where BCG is given, they've asked for a dipstick test. But again, the question here is you need not stop giving BCG because of that.
Okay, sir.
This finding of leukocyte will have no relation with having a advancement after the BCG. And actually, if you see you do a BCG and you ask the patient to come after second or third, you will find always some sort of leukocyte pyuria. This is something like an inflammatory response. And what if you see the literature mentioned is this BCG is immunotherapy, and it will take care of even if there are bacteria in the bladder and all that. This some sort of it will take control of the situation. So this is again a question which is asked about the pre-operative investigation before giving a BCG. It's important they ask, but you should know how to answer it. If you are doing it, yes, you are doing it. What is the important role? Yes, but it is not a predictor for any BC-related adverse event. Again, summarizing that dosing you should be aware of and interval, the timing for 2 hours and the disposal of that. Now, question here is our patient has taken BCG. He was okay for 2 to 3 induction cycles. Now he has come with the severe lower urinary tract symptoms. What you do?
Sir, I would like to do a urine routine and a urine culture sir.
Okay. But how to control the symptoms? You have sent it for all this.
Yes, sir. Conservative management, sir. I would like to manage him conservatively, sir, with the bladder relaxants and the antispasmodics in the form of.
Amit, any answers for this?
Sir, I would like to classify the patient according to the BCG toxicity grades. If it is severe symptoms, means it falls mostly in grade 2. So grade 2 will start with antispasmodics, antispasmodics, NSAIDs, antipyretics, do a urine culture, do an X-ray, and do an LFT. And start the patient on susceptible antibiotics, broad spectrum antibiotics like fluoroquinolones. And depending on the culture report, I'll change the antibiotic. If the patient is still symptomatic, I'll go ahead and start isoniazid and rifampicin till the symptoms are present.
Again, the idea of putting this slide is you should be able to classify the patient's local symptoms into how severe they are. Mild symptoms are known. If they are moderate to severe, then whatever we have seen giving bladder laxants, giving antibiotics, doing urine culture, ruling out infection, covering with antibiotics, everything is known. But if you have a severe symptoms, you should know what you do. But important thing is you should not miss what is the systemic symptoms. When you have a fever more than 102, where you need to how you tackle this systemic toxicity, Amit?
Sir, first we start with antibiotics, antispasmodics. Start the patient on isoniazid, rifampicin, and ethambutol in this case. And at the same time, the next dose of BCG, if we are planning, then we have to reduce the dose to half or 1/3. And till then, we postpone the BCG. We don't give the BCG till the symptoms patient improves. Okay. And in case of systemic toxicity, we continue the INH rifampicin for 3 months, sir.
Yeah. So some points have been nicely covered. One thing is you have not to take this condition lightly. The patient is in the hospital now. This patient is in the hospital. The patient having their constitutional symptoms, systemic symptoms, where you need to start now for the fever again, whatever paracetamol and all that. But this patient needs now antitubercle drugs, and whatever drugs he has told Isoniazid, rifampicin, ethambutol to give. But sometimes the examiner they ask because these drugs will act very late. No, any other drug which can give, yes, as a cyclosporin can be given, because usually it acts within 2 to 4 hours. This is second line drug for tuberculosis. Cyclosporin has also been mentioned in literature. Then definitely for systemic symptoms for the this patient, you need to give the steroids, 40 milligram of penicillin and all that. This is basically you should be able to split the local symptoms from the systemic symptoms. Coming back to the local symptoms again, there's a way of treating them with the local antibiotics, local antispasmodic, paracetamol, even institution of some local installations are also given. So different way, but these subside. There you can just decrease the dose, decrease the dwell time, increase the interval from 1 week to 2 weeks. Beyond 2 weeks, it doesn't help, or it's not indicated. But for systemic symptoms, yeah, you have to put a stop to the BCG. And this was just to put how to split the local symptom from the systemic symptoms. Systemic symptoms not to be taken lightly at all, because here the life is at threat. You can lose the patient if the patient goes to shock. Now we have a protocol of doing a cystoscopy. We have given this patient induction, and we did cystoscopy at 3 months. At that same time, we did cytology also. There is no tumor seen, and the cytology is negative now. What to do?
Sir, keep him on regular follow-up, sir.
Yes. So the patient was on regular follow-up. At the end of 6 months, when we did scopies, at that time he had already taken 6 doses of induction and 2 cycles of maintenance. Total around 10 doses of BCG is taken. A tumor was found around 1 centimeter. Now I'll give you a situation. Let us assume this tumor is again T1 high grade. What you are going to do? So we had a 3 centimeter, 3.6 centimeter. Now we have come to 1 centimeter, which is again T1 high grade.
T1 high grade, then he would be a BCG refractory, refractory tumor. So then I would counsel him for a radical cystectomy.
Okay. Now I just theoretically put what type of situation can be when our tumor was initially the high grade. And if you have a low grade and a TA recurrence, this can be what you can say repeat induction and all that. For any other where a T1 tumor is found after section of a tumor, this goes to a highest straight away, and this becomes an indication for
radical cystectomy.
So what I wanted to bring here is that in exam, it may come as a note, or examiners are fond of asking the types of BCG failure. I have just put on into that just to refractory, relapsing, resistant, intolerant. Now this unresponsive tumor has come, which has come in an AUA guideline also. A BCG unresponsive tumor is when a patient has taken 5 out of the 6 induction and 2 out of the 2 maintenance cycles, means total 4. After taking 9, you find a T1 TA high grade recurrence within 6 months. This is unresponsive tumor, and you should be try to figure out where your patient fits, unresponsive or relapsing on that. You can plan the treatment for that. Our patient is having a T1 high grade. Our patient will fit into
BCG unresponsive.
Yes, but you should be knowing that the examiner may ask, okay, if the patient doesn't want to go for radicostectomy, what are the other options available? Yes, you have other options. And Amit, can you tell me what are the other options?
Sir, we can give a second. We can resect the tumor. Biopsy has come as positive. Then we start on BCG therapy. Second induction is advisable. And still, if the patient is resistant, still if we have a recurrence, then we can go with systemic treatment.
Okay. Now, again, this comes into BCG unresponsive tumor. There are a number of options available, but again, ideally, this patient fits into a radicostectomy, where you have to just discuss the options with the patient, what is best for him. Okay. Now, coming to the intrathecal, you have number of options. You go from BCG. You can go with BCG with interferon. You can come to gemcitabine. You can come BCG with mitomycin, heated mitomycin, electromotive or hypothermia, and so on and so on. But why I have put this specifically, this 2 other option is to bring to your attention the newer form of intrathecal treatment, which is nadofaragene. So this is something like what you can say, it is a adenovirus which is tagged to interferon alpha. It is given intrathecally, and the initial results have been very good. You can say the muscle, what you can say, muscle invasive, the presence of muscle invasive disease at 3 months, 6 months, and 1 year have been found to be what you can say decreased with this, even the BCG unresponsive tumor. So this has been found to be a very promising drug, and this is better than the systemic treatment, which is in the form of immune checkpoint inhibitor, pamzolab, which is being given in the BCG refractory or BCG failures. So the intravesical nadofaragene is been found to be a little better in pamzolab in the terms of better efficacy and the terms of better safety profile also. But to add on to the various intravesical, I am putting just the different options available, which definitely include heated mitomycin and the electromotive installation of the mitomycin and so many other drugs. Am I right? Now, if you have to convince the patient for radical cystectomy, what you should be telling, it's very important how you put across to this patient with this patient having a BCG refractory disease, and it's important. This T1HG, this high-grade tumor, is more close to T2 disease. It's very close to T2 in terms of behavior. So you have to think that you're almost dealing with a muscle invasive, because the studies have proved that even in T1 high grade, you have 7% of lymph node positive, and if you do early cystectomy, 20% will have a T2 disease. So you already, this disease is very close to T2. So you should be very, what you can say, your counseling to the patient should be very appropriate. And the advantage of doing a radical cystectomy in this early, especially when you put a full stop to this, is you don't need an adjuvant treatment after that. Once the radical cystectomy is over, when you have a disease which has become T2, depending upon histopathology, you will have the use of adjuvant or not. Then you can do a nerve sparing also and preserve the sexual function, especially in younger patients. And the neobladder can be constructed, or it can be made in much more incidence as when the disease is what you can say T2. And when you do early cystectomy, these type of patients, they need little less extensive follow-up and lesser. So this, why I put it, this is recent literature, how to counsel the patient, how to tell the benefits of taking the radical cystectomy early when it gives a better results. when the chances of having the positive nodes are less, when the chances of having a T2 disease is less, rather than doing the radixectomy when the patient is a muscle invasive and have what you can say, more chance of local recurrence. So this is always better than the other intrathecal treatment. And
and regarding the counseling, regarding the survival should also be mentioned. So if you're doing a timely cystectomy, there's a chance of 10-year survival of up to 92%. Sir.
Yeah,
the patient survival.
We talk of 5 year.
Yes.
So
yes.
yeah, so this is absolutely correct. BCG failures, different options. Radixectomy will put it first. If patient is not willing, you will give the options of other intrathecal treatments, whatever are possible in your scenario, and which includes systemic treatment and pamazolave in the this is the discussion with the tumor board if you have, or medical oncology. So this is in short the management of this patient. Any question, any query you have, you let me know.
Sir, is there any role for radiotherapy? So if he's not willing for a radical cystectomy, is there any role for radiotherapy? Sir?
No, I think one trial is going on with the ERTC trial. I'm not sure about the result of this. The patient who don't want radixectomy, this is also being studied as one of the option, radiation. But again, radiation means complete TRBT. All the principles will follow under radiation. Yeah.
Sir, in the new EUA guidelines 2021, the indications for repeat resection, re-TURBT, restage TURBT, the high grade is not mentioned. I'm not sure if it is upgraded or.
No. It's a T1 which is mentioned.
T1 is mentioned. Incomplete resection is there, and if no muscle is present in the specimen, then it's there. But previous edition mentioned high grade.
Yeah.
So I'm not sure if it is omitted or is still there.
I'm not sure, but what I believe is any high-grade tumor has more chance of missing a residual disease. That is given in 2020 guideline also.
Yes.
And you have more chances of having a understaging. So these two makes the ground for it, considering for this, because what we have to deal with is if it's a high grade, whether we are talking about high grade TA or T1. Okay, if I'm talking of high grade TA, I have more chance of this TA which is getting understage. Okay, and if it is a high grade, it's a T1 disease, already we are doing it. There is no question of skipping restage TRBT.
So only thing which was missed out was TAG3. So TAG3, we are supposed to do re-TRBT or not? That was the question.
No, TAG3 is high grade only.
No, high grade is not mentioned, was not mentioned in the US.
No, I have this, whatever presentation I have put 2020 and 21 mixed.
Okay.
So this 21 guidelines have come in the month of March it has come. So, but if you see the 2020 guidelines,
it is there.
Yeah, it is there. So my question remains the same. High grade is a disease which is biologically different from a low grade, and it is what you can say when you talk about high grade HG, which is different from the earlier G1, G2, G3, or low grade, intermediate grade, and high grade. So this is something like a heterogeneous population, high grade. So what we'll do is, if you see our high grade has G2 also and G3 also. So somewhat, so it's a heterogeneous population. I'll always like to do a re-staging TRBT. The explanation given is understaging, residual disease and understaging.
Sure.
So there are a couple. Sir, Nitesh speaking.
Nitesh, tell me, Nitesh.
Sir, there are a few questions on Facebook. Sure. Can I ask that, sir?
Yes, sure.
Sir, whether random biopsy is needed in case of multiple lesions? I think we have already answered during this.
No, multiple. See, we have to let us assume we talk of a scenario in the post-op period where cytology is positive and ultrasound is negative and scope is negative. Now, what you are dealing with, we have to find out from where the cells are coming positive. So we are trying to look at to find out the cause. So random biopsy is there, prostate biopsy is there, extracellular cause is there, use of enhanced cystoscopy is there. But as a sort of a random biopsy taking when you have found a isolated tumor with no changes in the urothelium in other places, no. The biopsies has to be taken from areas which are suspicious looking. Okay.
Yes, sir.
Nitish, I am clear, and literature does mention the role of using a what you can say enhanced cystoscopy instead of white light, going in for PPD and what you can say narrowband imaging to biopsy these areas.
So in case of very large mass with imaging which is suggestive of muscle invasive tumor, should we strive for complete clearance or a adequate biopsy is enough? This is a question by Vishnu Bharti.
No, again, there is, let us assume you have a large tumor and you are thinking it is muscle invasive and you plan to do radical cystectomy. Let us assume I'm putting a very practical situation. This large tumor has no hydronephrosis or with hydronephrosis. So if it's hydronephrosis, it is what I can say is it is almost a surrogate marker. This may be muscle invasive. So let us assume this is a large mass which you think it is on CT is going beyond the wall. But still, for radical cystectomy, we need to have a proof of muscle invasion. You need not go for the section of whole tumor because your treatment plan is different. You can go to one sector of the tumor where you can resect, go to the base of the tumor, prove the muscle invasion, and then. You got my point or not?
Yes, sir. Yes, sir.
Unless until the radical cystectomy for any reason is ruled out. Say your patient is not fit, the patient is very old age, he may not withstand a radical cystectomy, then our same protocol will be there, maximal TURBT, whatever complete section of the macroscopic tumor can be carried out.
Sir, with the present imaging, is it mandatory to do bimanual examination? Whether it will change the management? This is a question by Ishwar.
That's why it is absolutely correct because now we are doing the staging, clinical staging after imaging and the biopsy report is there. So it doesn't, but some examiners are fond of asking this question, how to pick up the residual tumor, how to pick up extravesical tumor by manual, because there were conditions when the this resection was done without cross-sectional imaging. They were doing ultrasound and then going with the resection, and then after the biopsy report, the further imaging used to be done.
Sir, what about if there are multiple tumors? Should we take deep biopsy from each and every tumor? And what about deep biopsy, whether the entire floor should be resected or only we can take from the margins?
No, see, when you are talking about multiple tumors, you are already putting this tumor into high risk. From high to highest risk is already going. You are you have adjuvant treatment in place for this tumor. So what we have to do is the largest tumor will be resected like a primary section with a base, and other tumors will be resected superficially.
Sir, for exam purpose, if the tumor is less than 3 centimeters or a small tumor, only ultrasound is enough, or we should tell CT scan also? No, this is a question by Wasim Ashraf.
And again, we discussed this. So this both ways we are right. If you see the EAA guideline, they may say 3 centimeter or less than 3 centimeter tumor in the lateral wall, you can go ahead with the ultrasound, do TURBT, and then stage later. But if you see the protocol of visible hematuria, where the contrast CT and CT urogram is done for every patient, irrespective of tumor is found of any size. EAU guidelines do the CT scan, keeping in view select condition where they have what you can say chances of picking up upper tract tumor, especially in the trigone, multifocal tumors and high-risk tumors. So that is the way guidelines, EAU guidelines put it.
And how to manage bladder perforation during TURBT?
No, it all depends on extraperitoneal, intraperitoneal. I have not discussed this. Intraperitoneal, you know that we have to stop in between, and you have to see the abdomen and all that. Whether bladder has to be drained, and whether peritoneum needs to be drained. You have to see how late you picked up. Whether this abdomen needs to be drained or not, with or aspiration has to be done. Extraperitoneally, hemostasis, and just put a catheter and come on. You have to come back again.
Fine. Sanjay, Amit, do you have any other questions?
No, sir.
Sir, yes, sir. So one last question, sir. Suppose we do a random biopsy for the cytology positive and cystoscopy negative condition, sir, and the random biopsy also becomes negative, sir. So what is the next step, sir?
No, patient, see, you have ruled out the prostate. You have done a prostate biopsy also. You have
Yes.
ruled out the upper tract.
Yes, sir.
You have done the imaging. These patients are kept for follow-up.
Yeah.
Yeah. So
any role of
they have the separate follow-up protocol for upper tract imaging also, which is included in the follow-up. If you see our protocol is usually with the cytology and cystoscopy, but in where the species cytology positive, the upper tract imaging also comes into the follow-up protocol. So periodically we have to do a sectional imaging because somewhere they will manifest.
I think with this we'll end today's session. It was a wonderful class.